This conference will now be recorded.
All right. Apologize if there's some background noise where I am. Okay. So I have two cases that I found just this past week or two that are both, I think, just really good examples of sort of classic findings. So here we have frontal chest radiograph, and obviously, right, not a very subtle abnormality. We have all of these areas of sort of mass-like opacity projecting over the mediastinum. On this frontal, we can clearly make out the border of the right heart, border of the left heart, border of the aorta, as well as sort of the paratracheal stripes. So, and, hilar vessels as well, we can clearly see. So all of that's suggestive on this frontal that whatever these masses are, they're probably not in the middle mediastinum. And, not a huge diagnostic conundrum. We do have a lateral, and we can see that all of these are posterior. So when we're talking about multiple posterior mediastinal masses, sort of the first things that come to mind are going to be neurogenic tumors, and then what this turns out to be, which we do have a CT from. So we can see that these masses have quite a lot of fat density intermixed with soft tissue density. There are multiple of them bilateral surrounding the spine. Some of them seem to be associated with the underlying ribs a little bit. We do see some anteriorly as well. And then if we actually look at the patient's ribs and bones, we can see that they're pretty markedly abnormal. This patient, I think, is maybe 40 years old, so relatively young, and we can see all of this abnormal osseous appearance. And so this is a patient who has beta thalassemia, and what these end up being are extramedullary hematopoiesis. This was just sort of the most dramatic case of this that I have seen in quite a while.
Absolutely. You even see it inside the ribs
Yeah,
anteriorly.
yeah,
Crazy.
exactly all this.
Yeah.
Can you go back to the radiograph? I thought the ribs looked a little
Absolutely.
funny.
Yeah, I agree. I think like if you look at the clavicles too, they look just way too lucent for
Right.
somebody as young as this. And yeah, the ribs too, especially down here, you can see where you've sort of lost any sort of normal central opacity.
That's beautiful.
Oh, yeah.
Yeah, great case. I have a question for you now, thinking about this. If you need to make blood cells in other places and you do so like this, what is it about the fact that there's fat there? Why do we have fat in these lesions? And quite a lot in this case. Um, because fat's not the problem, blood cells are the problem. But that happens frequently. Does anyone have any sense
Yeah.
of what it is about the process that sometimes there's a lot of presumably just plain old adipocytes there? Something about that that's interesting. And I don't think I know.
Uh,
I'm sure I
I
don't
mean,
know.
other than the normal fat, and maybe it's just part of the marrow tissue, but yeah, I don't know
Mhm.
why you would produce extra fat there.
Yeah,
Yeah.
Interesting.
it's interesting. It's so much of it.
Yeah. I agree. I wonder whether, because you're right, I always just assume it's similar to just the composition that is normally in marrow, but
Yeah,
why do we
right.
need the fat in marrow? I don't know. I
Yeah.
don't know the answer to that. It's a great
Cool.
question. Cool. All right, and then this was my other case. So this patient came in acutely with pain, though interestingly abdominal pain. And this was a chest radiograph that they had. We can see that there's obviously some opacity involving the right hilum. Right, it looks pretty localized to the hilum itself. I don't know, maybe the contour of the aorta is a little weird. It's kind of hard to tell. The patient's a little rotated. Um, but this is their CT, which explains their right hilar abnormality. Let me window it. So once it unfuzzes, all right, we can see acutely patient clearly has an acute aortic dissection, which is involving the ascending aorta. There's this little contour regularity here. And we can see all of this density tracking along the main pulmonary artery, right and left pulmonary arteries, all the way out to these distal branches. Really
Mm,
far out, actually. We can see it going all the way to these like subsegmental pulmonary arteries. So this was just a um, extension of this Sorry, I'm getting some feedback from somebody. Apologies. So extension of blood along the shared adventitial sheath between the aorta and the main pulmonary artery. And we can see it sort of on both sides. And interestingly, if you look, you can see it sort of surrounding all of the pulmonary arteries, but not around the pulmonary veins as well, because obviously the pulmonary veins don't share that same adventitial sheath.
That is one of the more extensive ones I've seen going
Yeah,
out that far. That
I
is
agree.
really impressive. You know,
I
you
think I've
wonder,
seen
I
it
mean,
around.
that's such a decompressive mechanism. I wonder if, if you did, I mean, I don't know, it'd be hard to study, but you wonder if that's somewhat life-saving because it prevents it from going somewhere else.
Yeah, that's a good point. I think ultimately this patient unfortunately did not make it, but you can see just like how extensive this dissection is. You can see there's no perfusion at all getting to the
Oh
splenic
gosh.
artery as well as the celiac trunk. Most of it, there's just this trickle going to the liver. So I don't know whether it was just the dissection itself or whether they had like frank ischemia of a lot of things. And we do have a non-con. Oftentimes you can see high density associated with on the non-con. It's not super impressive on this one, unfortunately. It's not as nice as I would like it to be, but yeah, just a good example of this mechanism. Cool. And those are my cases.
Great, thank you, Maya.
Excellent.
Thank you.
All right, Howard, do you have cases?
I do.
All right, I'll make you the presenter.
I was going to try and share my entire screen if I can. Figure that out. Screens, entire screen. Okay, let me know if you do not see my
I see your
database
database.
uh,
I see,
in the window
see,
as well.
I just see your database window.
And now,
Now I see an image.
okay. So here is a series obtained during placement of an Edwards Sapien aortic valve device in the usual transcatheter approach. So I will scroll through this series. I'm just going to click. And for those of you that haven't seen this before, this is a so-called balloon expandable device. Again, it's the Edwards Sapien device. So here we go. Let's see if I got this correct sequence. Okay, here we're beginning to see the balloon expanding and the device opening during the procedure. And oops, I'll go back.
Oh
Lift off.
no.
You don't
Ooh,
want to see that. You don't want to see that during the procedure. So here is, I don't know the frames per second here, but there it is. Lift off. Not good. And it has moved from its intended position and ends up here. And then I'll tell you some more about this in a moment. And then I'll show you that they went on to, actually, I'll show you this because they're going to fix that in position, balloon expandable, now in proximal descending aorta. And they deploy another one in the proper position. So by way of background, here you can see during the procedure on these images that there is this right ventricular pacing lead. So the way they do this during the procedure is, in order to avoid this issue, they use this right ventricular pacemaker lead to pace the right ventricle rapidly. So there's rapid right ventricular pacing. And they achieve a quick heart rate and a drop in blood pressure, stroke volume ejection. during the deployment of the balloon. So here is the note from the op report to indicate what happened in this particular instance. And this is just bad luck, so I'll read this to you. The temporary pacer briefly lost capture. There was a premature ventricular contraction, ejected the valve, and you can see what they did. They pulled the valve distally through the aortic arch and fixed it in that position, and then put in another valve. So that happens. This is a radiograph that would explain, if you didn't know the history, why there's one here and one here. And this is a temporary right ventricular pacemaker lead. I think, I'm trying to remember, someone showed a case of this in the webinar before.
I think Travis
This,
did.
Yeah.
I
So
think Travis did.
so the valve, the other valve there, do they do anything with it so it doesn't act as a valve, or?
No, they just basically fixed it against the wall.
Yeah, I think we have almost
And
an
no,
identical case here that Travis may
basically,
have shown.
okay, yeah, I
Uh,
think you showed that one.
mhm.
And basically, it's a valve and it's there, but it, opens up and doesn't impede blood flow, so no big deal, as far as I know. If it ends up in that location, it's fine. Does anyone know any differently?
No, the
This
ones
is
that I've
follow-up.
seen here, they just exactly as you said, they just move it so that it's not blocking the arch vessels because sometimes it
Yep,
gets lodged there when it embolizes, but once it's
right.
past that, they just leave it.
Yeah, yeah, exactly. Yeah. So this CT was actually in the context of an oncology follow-up, and a colleague of mine saw that and said, "Hey, wait a minute, something's weird here." And then, of course, we went back and got the history. Yeah, so interesting. I didn't actually know the details about the rapid ventricular pacing that they do, but now I understand it better. Okay, this is an interesting case. These are images from the outside. I encountered this case post-op, and the finding really is not one that one can diagnose on radiography. And I don't know how this was discovered, but these are images. And it says CTPA, so maybe the patient elsewhere had chest pain, and there's no PE, but a discovery of this subcoronal opacity. So when we look at that and we look at its attenuation, it's kind of similar to soft tissue, muscle, for example. Doesn't look like water. And let's scroll through that more carefully. Does it have areas of low attenuation within? No. No calcium. Now, let's have a look at vessels. Actually, I'm going to make this a MIP. So we'll make that a MIP, 3 millimeters. Let's look for feeding vessels. Here comes an intercostal or a vessel going into it. Let me make this a bit thicker. Here's some small vessels here. So there are a bunch of small vessels that are supplying this tissue. So subcoronal mass. Here is the PET, and it shows mild glucose metabolism, not particularly hot. So there's a differential diagnosis for this, but anyone want to throw out, just for fun, a couple of possibilities?
So where's the
Not a cyst.
esophagus in all of this?
Okay, that's a good question. Let's see. So it's not esophageal
There it
here.
is
It's
right
not
there.
distended. It's not distended, and it goes alongside it. And let's see, it comes out the other side, somewhere down there. So it's not centered in the esophagus, and the esophagus above is not
Okay, so,
distended. Okay,
well, with the
so,
vessel, you'd wonder about Castleman disease.
okay,
Um,
kind of vascular.
It's
Um,
not vascular enough for like a um, uh,
Paraganglioma, say.
thank you. Yeah,
Yeah,
they're usually a lot more hypervascular than
usually
that.
they're much brighter,
I mean,
even
if I,
relatively early in the
yeah, it's
sequence.
really
Huh?
smooth, whatever it is.
Yeah.
Lymphoma, maybe, but yeah, I like Castleman disease given the vessel and the sort of confluent mass.
Hmm.
Bingo. There you
Nice.
are. Look at
Nice.
the nice description over
That's
here.
awesome.
Mass with hypervascular with innumerably small vessels feeding the mass. A really nice description of the typical findings of the hyaline vascular variant unicentric Castlemans. They did some stains for lymphocytes, and let's see, another stain highlighting vessels. Yeah, pretty neat case, huh?
It's interesting because the examples you sometimes see in some of the older books and are like like really hypervascular looking, but in reality, the handful of cases I've seen have always just been they look like lymphomas with a lot of vessels or lymphadenopathy that may be a little denser than normal, but they just have a lot of feeding vessels in them rather than like something truly bright like maybe a carcinoid tumor.
Yeah, exactly. Yeah, I think this is the second one. I think maybe Travis showed one. I think it was Travis or Dave a couple of weeks ago, if I remember correctly. Not unlike this one. It turned out to be exactly the same thing. Yeah. And I think it was subcoronal too, if I remember correctly. This is, I showed a case like this in the very recent past, and particularly for trainees, made the point that if you have a patient with a pacemaker, and of course, if there's any hint that they're obtaining the radiograph because of a concern about the functioning of the pacemaker, you need to zoom in. And let's see if I got the right, make sure I got the right case. Sorry about that. I'm going to go back, try and fix that up. And the place to zoom in a lot in cases is the costoclavicular space, because the wires in that particular location um, are subjected to stress during activities of daily life. Now, this is really subtle. So we've got three items there, but right here, there's discontinuity. It's not a, I can't see a frank fracture of that pacemaker electrode, but when they examined this patient, they got um, substantial abnormality, abnormal impedance related to the atrial lead, which they subsequently replaced. And I think it is at least disrupted enough here to produce that. So that's the
Yeah,
place to zoom in really carefully, because
it
otherwise,
looks like the insulation maybe failed there.
Yeah.
yeah, there's definitely a little
But I
gap right there.
agree with you, the wire looks intact,
It does seemingly look intact, but there
which
was
would
enough
explain the
abnormality.
impedance issues, whereas if you have a frank fracture, that you shouldn't even get the signal from the right atrium.
Yeah, it was definitely an increased impedance, and they replaced
Now,
that.
Howard, one of the things,
Yeah,
so we've seen a couple of these, but one of the things I've noticed though is sometimes there's like natural lucencies in the insulation. And the yours looks more irregular, but have you encountered that where on close inspection it looks like there might be something, but you realize it's just the way it is made?
I'm not sure um, in that location or just in general.
Just in general.
Yeah, I think I may have counted cases where I'm looking and I'm not really sure it's a real fracture. Sometimes you can get apparent defects that now it's not in this case, but sometimes you can see here, and this is a different issue, of course. You can get abnormalities or what appear to be abnormalities related to the suture sleeve. Now, with respect to suture sleeves, there are kind of two varieties. Here you can actually see the plastic of the suture sleeves, and there are two of them. But sometimes this plastic is not really visible, and instead of that, you can get little constrictions where they have the sutures of the suture sleeves. And sometimes that can simulate an abnormality. And that's typically is closer to the pacemaker can itself rather than up here. Now, of course, here we can see the suture sleeve, so that's not the issue. And you can see there's no constriction. So sometimes I've looked at that and wondered whether there's an abnormality, but I'm not sure otherwise, Jeff, about
Okay. Some of them are like the insulation has little segment rings, and I think it's just I have a case I'll show where you can see the
okay.
diff as it bends, it changes the distance between them, and it can look like a discontinuity.
Yeah. Yeah, I'm sure there are cases where one isn't sure. This one is a little bit odd. This is one of the most subtle ones I've seen. And the cardiologist mentioned that he discorded a fracture. I guess he was armed with the information about the impedance changes and the other things that were going on and replaced the atrial lead. Okay, those are my cases for this week, Jeff.
Excellent. All righty.
Those are great. Thank you.
I can show a few. Okay, let's see. You guys see my Osiris database?
Yes.
Okay. So this
Yes.
is an elderly patient who had a paraesophageal hernia repair, and it was a pretty big one. I don't have the preoperative imaging, but it was complicated by a small esophageal injury. So they put a stent across the defect, but then afterwards the patient wasn't doing well. So we did a CT esophagram to evaluate what was going on with the stent. And you can see there's this big left effusion, there's atelectasis, and you can see this column of contrast filling the esophagus. And then we get down here in the lower mediastinum, and we can see this very irregular collection. There's gas, there's contrast, and then we get into the stent here, and you can follow the stent into the abdomen, into the stomach here. So if you look carefully, if we come right up to the proximal end of the stent, we can see there's a defect right here. And I actually made a montage of this, and you can see right there is the defect. Here's a MIP showing the esophagram. So what they thought happened, and the defect was actually down here, and that's fine. So what they thought happened was the stent probably eroded through here. It probably injured it while it was being placed, or something like that, and caused this tear right at that proximal end. So they ended
Yeah.
up putting a drain in up into this area here, and then also draining the pleural space. And then on a recent study, we did see that this had finally kind of closed itself off there. But it's a nice use of CT esophagography to look at this, and you can make like the old school images by doing stents and all that like that. All right.
Good.
Let me show this case here. This is relevant to Howard's case. So this is what I was talking about. I apologize. Someone decided to turn on their truck. You can see this pacer here. See how it has the more corrugated look to the
Yes.
insulation. You can see there's like little gaps in different areas. This one's not so bad, but sometimes I've seen them where they stretch out more, and sometimes I wonder if
Okay.
there's like a little disruption in there or not. But
Yeah.
anyway, the
No.
reason I'm showing this case is this was a routine pacer placement. Patient had no previous imaging with the pacer in, and this was supposed to be a dual chamber pacer, so right atrium, right ventricle. And you can see there's a lead coming into the right ventricle, and this one was targeted towards the septum, which they sometimes put it there. Sometimes you also see it directed towards the apex. But this lead here is going down. Hold on just a second. Right. You can see it's pointing down, and they almost always park it in the right atrial appendage, so you'll see it come down and make a loop up. I've occasionally seen it go sideways, but I've never seen one come down this far. And so if you look, luckily they put their procedure notes in, and indeed they had put it in the right atrial appendage. So this had come out right after the procedure. I mean, the patient, after coming out of the PACU, the first thing they do is they send them for a 2-view radiograph once their sedation is worn off, or if they use whatever anesthesia. So this is usually within hours, if not just a couple of hours of the
Yes.
procedure. So this was an immediate post-procedural complication, and they're not always aware of this because they test everything in the cath lab before they leave, and everything's working fine. So when I was discussing with the electrophysiologist, yeah, they just were going to go back and revise it the next day.
Yeah.
So if you're used to seeing them, it's pretty easy to pick up that it's not where it's supposed to be. But if you just say routine and you assume this is where they're supposed to put it, and you don't have a comparison showing the dislodgement, you could just pass this, and they won't pick it up until they interrogate it later the next day. Okay.
Do they
This
typically keep the patient overnight as well at your place and then
yes, they do.
radiograph the next day?
Excuse me. Yes, they keep them overnight. And then yeah, they usually get sometimes they get a portable in the depending on how heavy the sedation was, they'll just get a portable in the PACU,
Yeah.
and
And
they
on
get
that
a 2
lateral
20.
projection, are the patient's arms down? I'm just curious.
One of them is, yeah.
Typically over here, they tell the techs and the patient, don't let anyone pull your arms down, up,
Right.
excuse me. So typically we see the arms actually just straight down lateral.
Yeah, same at ours.
Yeah,
Yeah.
yeah.
But you can see that one hanging out where it's not supposed to be.
Hmm.
Nice.
Okay. And I haven't seen one of those in a while. I've seen them get dislodged, but I've not seen them the first go. So this is an interesting case, just from a pathology. So this was I don't remember why the next CT was done, but for whatever reason, this was identified on the next CT. You can see there's this heterogeneous peripherally enhancing mass. It's got some calcium in it, located in the upper mediastinum. It seems to be abutting the brachiocephalic vein and the on both sides and up against the arch. And you can see it doesn't seem to attach to anything else. So it's kind of just hanging out here. Now our next CTs are sort of a dual phase. They use quite a bit of contrast. You can get this really robust enhancement. So they ended up doing a chest CT later on to figure out what else was going on in there. And there's the mass. It's got this calcium in it. If we go up here, you can see there's just thyroid, and there was nothing else in the chest. So they did a biopsy of this, and I was kind of surprised by the path. I thought this might be like I mean, the calcium. I mean, we have so many calcified lymph nodes around here. I wondered if it was just in a pre-existing node, um, but I was wondering if this was just going to be like a lung cancer, a small cell, given how necrotic it looked on the next CT. Occasionally, we'll get like just what looks like a primary, another type of lung cancer where we don't see the primary, but this came back as papillary thyroid carcinoma.
Oh, geez.
And I can't connect this to the thyroid. I'll show the neck again. So
Really?
I think this is ectopic thyroid tissue that developed the
Wow.
cancer. Because I think, this looks like typical hypervascular thyroid tissue
Yeah,
like we see here.
Yeah.
And this is necrotic. And we see calcifications in little thyroid nodules all the time, but yeah,
right.
I was kind of surprised, and it's kind of in a rough space here, but they were able to actually they had to do a VATS to get tissue here because it's in a really tough spot, but does not look like it's going to be resectable based on this vein involvement here. But that was not what I was expecting to see. I've seen true ectopic thyroid just a handful of times. Often you can connect these little what look like masses to the thyroid gland. And then I think David's shown one, and I've seen a couple of cases like with truly as a mediastinal mass, but never a
Yes.
thyroid cancer.
Yeah.
And there's nothing in the gland to suggest it's a met. So
Now, what about the possibility that it's just contiguous to the adjacent vessels, and if they decide to, I mean, they can take it out maybe easily?
yeah, I mean they might be able to. I mean, you in theory could take the right brachiocephalic vein if you needed
Oh,
to.
it's hard. Yeah, it's hard to tell invasion and so on.
Yeah, and because it was a VATS just for a biopsy, they didn't
Right.
try to resect it.
Yeah.
So They could also, it's a papillary. They could try to treat it with radioiodine radiation. I don't know, maybe something, but it's just it's a weird tumor. Alrighty, and then this last case is kind of a fun one, something we don't see a lot of. This is a young man who was in an ATV crash, and the injuries, if you don't look for these, they're easy to miss, and that is, you have to look right in here at the sternoclavicular joint because sternoclavicular joints are usually, I think you're better off seeing them on coronals, but it's an easy place to overlook on a trauma. I mean, we're always looking for rib fractures, clavicle fractures, sternal fractures. And this joint, depending on where the position is, their arm can change position, but you'll notice the alignment here on the left, the sternum, I mean, sorry, the clavicle and the manubrium are lined up, and there's a joint capsule here. On the right, you'll see there's this clear step off, and
Mm.
he's 18, so he hasn't even closed his physes yet. So that's what that bone is there. So this is a posterior dislocation, and this is actually a fairly it's not that common of an injury, and it's usually associated with high energy trauma because it requires a direct blow that disrupts this capsule. Sometimes you'll see it with a distraction injury, but it's usually associated with severe injury to the arteries and the vasculature and the brachial plexus. And there's often a lot of fractures here too, sort of the thoraco what's it called, the dissociation. But in this case, it was a direct blow, and because he's young, his bones are pretty tough. It probably the capsule gave rather than the bones. It can be associated with impingement of the brachiocephalic vein, also injury to the right brachiocephalic artery or any of its branches. But it looks like in this case it was a pretty clean injury. Now, he had a portable radiograph on the outside that wasn't particularly very good. It's really hard to see, but I did find this contemporaneous. I don't know why at the outside hospital, his trauma must not have been so bad because they did a rib series rather than the usual trauma workup. And all you can really see is there's a subtle difference because it's pretty well centered in the alignment of the clavicular heads. But I'll have to be honest, I think that's a really hard call to make even on a good
Yeah.
day. Um,
Yeah.
because that's one of the things I always
Right.
look for on the trauma radiographs is usually one of these is just it's either too far over or it's elevated when that capsule because the muscles the will elevate the clavicular head. You just see it's a very subtle elevation. So I call this would be a retrospective finding. I would not call that prospectively. Let
Right.
me just show the coronal here. We can see those nice, yeah, here we go, put some bone in those on. There we go. You can see really there's the normal joint here on the left, and then here's the abnormal. You can see, we should be seeing the other clavicular head, and we don't because it's
Hmm.
back here. So
Yeah.
sternal, it's supposed to here. So yeah, he's lucky he didn't have any other injuries associated with that. I think he did have some small contusions. Yeah, he had this nice little contusion down here, a little tiny laceration, but that was the extent of it. So he got really lucky. So we were trying
Yeah.
to figure out, these ATVs, sometimes they're driven around and on like trails but also in
Yeah.
on farms. And so sometimes they go, because they're not wearing seat belts, they crash into the steering mechanism, and that could cause a direct blow. Or if you got thrown off and hit something, that would cause
Yep.
a direct blow too. So, but enough force
Jeff,
to do
if you
that.
go, yeah,
Yeah.
just a cute finding. If you go to the lung window, I think I saw just for grins a small traumatic lung cyst.
Yeah, a little laceration right there. And
There's
there's
another
another
one
one right
that's
there, right
paramedial.
immediately.
There, right there.
Yeah,
Yeah.
yeah, it goes
Isn't
with
that neat to see where they
that
form?
anterior
Yeah.
bone, and you can see the contusion. Where was it? I think it was one up
Yeah.
higher. Yeah, right here crosses the fissure because they
Yeah.
don't respect anatomic boundaries because of the force
Right.
vector there. So
And another thing that I've seen, I don't think I showed it at the webinar, but I've seen one or two this year, is you have an injury on one side and you have contre-coup, little subpleural traumatic lung cysts on the other side. That's not uncommon.
yeah,
And
I think less common than you see in the head because there's a little bit more give in the chest. But yeah, you
yeah,
do have to, and it depends on the mechanism. I think you see it more when you have a lateral force
mm,
and the lung kind of rapidly accelerates and then decelerates, and often you'll get a quick mediastinal rotation. And when the compressed left lung if the force were coming this way, if the left lung were to re-expand rapidly, it can cause a laceration there. And then sometimes you'll see the very long vertically oriented ones where the lung slams up into the spine and rapidly
Right.
compresses and decompresses, and then you get
Yeah.
that so-called type 2 laceration from the rapid deceleration. Yeah, the trauma is interesting if you think about it from a mechanistic standpoint, and it can help explain injuries. Also, it can help you kind of predict what you might see and make sure you don't overlook those other injuries. But yeah, so a nice posterior sternoclavicular joint dislocation. Anterior ones are really, really rare. I'm not quite sure how you'd possibly do that, but I've only seen a handful over the years, so they don't happen very often. And this guy, like I said, they can be associated with vascular injury, so that's what you want to look for and make sure there's not a pseudoaneurysm or impingement of the brachiocephalic vessel. All right, well, that is all I have. So we will, that's not what we want. We will call it a day.
Great.
And
Yeah,
thanks for the
thank you,
great
everyone.
cases. And everyone have a good
Yeah.
holiday weekend, and
You
be
too.
back next week.
Okay. Cheers, everyone. Thanks.
Yep. Bye.
Bye.